any more stories? Thanks.
I think we're good now. Thank you for your patience. So presenting with me as well is Dr. Mendoza and Shannon, our partner at CleanSlate, where we couldn't do this without her. So last August, Governor Baker signed into law that all emergency rooms in the Commonwealth are required to provide medicated assisted treatment as an option for people who come into the emergency room for a variety of reasons. Some people come in, as you know, from an opiate overdose. Other folks come in seeking detox, seeking services themselves, or they come in for medical reasons related or unrelated to their use. And it's a great opportunity in all of those cases to have this available and an option to the folks that we're trying to serve in the emergency room. So we want to give you a really quick context of why we're doing this, and then and give you a better understanding in the field of what it will be like and what the experience will be like for an individual who either you help get to the emergency room or are following up after emergency room of what's happening from our perspective. There we go. So just want to provide some context. This is not a new slide, probably all of you. We've seen this before, but it's a really important reminder of why people are using. So here in the beginning, they're on prescribed medications, or they're choosing to use or to get high, and they're experiencing this euphoria. Where we end up seeing them following overdoses or seeking detox is towards the middle and the end, where they're using just not to get sick. They're no longer experiencing that euphoria. So those are the folks that we're really looking to kind of work with, get into treatment, and offer them many different pathways to treatment, including medicated assisted treatment.
Hello, everyone. So I think this slide right here just shows, the green line going up, it's when we have no medication at all. It's really important to remember that somebody that is, using consistently, really the end result most likely is death unless they find recovery. So when we introduce these medicated assisted treatments, such as methadone, which is the second line, or buprenorphine, which is also known as Suboxone, which is the yellow line, or the naltrexone, which is the blue line, it really just takes that cause of death and just brings it down. It's really important. We hear a lot of times, well, we're just taking one medication and substituting it for the other. That is really invalid for us. We are just trying to save lives. It's whatever works. It's medication if that works, it's yoga if that works. Really, it doesn't matter what we're using to help the person stay sober. But I mean, the results are right here. I mean, using medicated assisted treatment definitely helps save lives. It helps people get their lives together, puts more tools in their toolbox in order to get everything else together. Once you kind of bring down the using, you can start working on maybe getting a job or housing or counseling. Everything kind of going together will help them on the right path to make sure that they are leading a healthy life to recovery.
I'm a board-certified addiction psychiatrist. I'm not just a hair club president, I'm also a member. I've been dealing with substance use for 3 decades, and there's nothing more frightening to an addiction psychiatrist than having to do this alone in an office. And what I wanted to say is that in 2019, this represents an exciting opportunity to showcase this model that we've developed in Plymouth. And this model is not the MAD program. This model is about taking advantage of all the networking and all the community relationships we've developed. Scott, Mike, Dick Linehan, John, and I even have my old friend Ken Lawson from Duxbury, relocated to Brockton. Better house values in Brockton, obviously. But we have this opportunity to take this outside of just the clinic, just outside of the hospital, and build a continuum of care. We have the drug courts, and Sarah's going to talk about most of that. And I think what happened was in 2013, we got a Chart 1 award, which allowed us to build an embedded clinical practice where a social worker with a part-time psychiatrist. We got the Chart 2 award in 2014, which allowed us to build emergency department behavioral health, build a system to take care of the complex dual insured patients. How did that happen? Did you do that? And then we also were able to build an integrated care initiative, which is essentially embedding social workers in multiple primary care sites. On top of all of this, we had a drug court, and then Sarah was able to work with the boys, as I call them affectionately, in building out at that time it was Plymouth County? Project Outreach, and now it's Plymouth County Outreach, and this is spread all over the South Shore and the Metro South. And then we were able to get the Project Matter Award. We were the only BI hospital that got the Project Matter Award. On top of all of this, we have the BI and the Lahey merger. And what's interesting is that Attorney General approved the merger on the condition that we focus on behavioral health and substance use. And to somebody who's been practicing psychiatry for 30 years, it's downright amazing to be told by the leaders of the 11 hospitals that behavioral health is the focus. So I sit on the executive committee as we build this out. So what we have in Plymouth is ultimately a scalable model that I think we can extend outwards to the rest of the hub. The other thing that we've done, and I wanted to do a shout out to Dr. Gary Maestas, is that we are the only site in the US to have Preventure. Preventure is a SAMHSA endorsed evidence-based treatment model, which has both a primary and a secondary prevention mode to it. And we don't have time to get into that. We're happy to discuss this further. This was presented along with Plymouth County Outreach at the Silverman Institute a couple of weeks ago by Sarah and by Jen Pinto, and it was exceedingly well received in Boston. And we're going to have training in August for Preventure. So as you can see, MAT in the ED is just a tiny piece of the model that we have tried to build collectively. And it's not me, it's not Sarah, it's everyone in this room. And I'm hoping that we can continue building on this moving forward.
So this slide isn't intended to do these Plymouth County's response to the opioid epidemic and all the programs and do it justice, but I just wanted to highlight that two things. One is that we've come a long way in the county collaboratively since 2014, and then secondly, medicated-assisted treatment is only a small part of the programming. It's really important to have it as available, but there's it's a lot bigger response and collaboration. So Project Matter, Dr. Mendoza referenced, it's an acronym for medicated-assisted treatment for transformation and extended results. It is funded through the Health Policy Commission. Beth Israel Plymouth is one of 15 awardees of this grant, and 9 of those are focused specifically on medicated-assisted treatment in the emergency room. So Brandeis University is going to be evaluating all 9 medicated-assisted treatment emergency room programs. So we're going to have some data to share as well at the end of this process. So it's a 2-year grant cycle. We've already had a planning phase. We have baseline data, and we went live in May. And our target population are folks who come into the emergency room, either through a Narcan reversal, some evidence of opiate use, some clinical indicators of OUD, or self-presenting requesting help. And a few of the data points we're going to be looking at is the number of folks that are enrolled, how many are agreed to induction in the emergency room, and then we're going to look at time points into the future, working with CleanSlate and other community providers on are they still engaged in treatment 30 days, 90 days, 180 days, and whatnot. So we were very fortunate in Massachusetts that we have the Massachusetts Health and Hospital Association that put out guidelines for all of the hospitals and all the emergency rooms on how to do this. So we're going to have a lot of consistency amongst our community emergency rooms, hopefully, on protocols, procedures, and the process for rolling this out. So we are very involved in that work group, and this is really the how-to guide. Do you want to talk about the process?
Sure. Is there a pointer here?
No.
There it is.
Oh, there is a pointer.
So as Sarah referenced, the MHA had this group of experts, and Sarah, Steve Nicholson, who's also an addiction psychiatrist and the vice chair of the department at Plymouth, and I were involved in that. And it was a very gratifying collaborative learning experience, because I can tell you that everything we've done was a work in evolution. It was really truly an organic process. People were actively changing their guidelines each and every time we met. And this is a culmination of that work. And I urge you to read the report from the MHA. It's probably more exciting reading than the Mueller report. But it also gives you a sense of the thought process that came in. And this we adapted specifically for this community. So if you go up here, can you guys see the red dot on top? If somebody comes in with an overdose, in the old days, those patients would not be a candidate for Suboxone. However, collectively, the task force came to an agreement that this is exactly that patient population that will sign out in an agitated fashion and will be dead within a year. I mean, the risk of lethality or death from an overdose is much higher a year after going to the ED. This patient will be offered a chance to get Suboxone. And this patient will not have to go through the RODS screen, and I'll go over the RODS screen. The RODS screen is a screening tool that was developed by Jeffrey Wickersham as part of the Yale New Haven study. And this is what happens when you get old. You can't see anything anymore. Can't see that too. When we performed the initial COWS quantitative assessment, and if the COWS score is greater than 10, that patient is a candidate for Suboxone. And the dosing we have is 4/2 milligrams. We repeat the COWS in an hour, and if the COWS is still greater than 6, we administer another dose. From experience, collectively, we find that 16 milligrams is probably more than enough for most patients. And then we decide at that point if the patient can go home, and depending on what day of the week it is, we can either discharge the patient directly, and Sarah and Shannon will talk about the referral process to CleanSlate, or if it's on a weekend, we have take-home kits that we can go in. And this took a lot of work in conjunction with our pharmacy, but I think we're at the point where this is smooth in the process. The other thing we did is we came up with an electronic order set, which makes this a seamless process for the nursing staff. Now, this is the other patient population, the one that comes into the ED for other reasons, not an overdose. It could be cellulitis, it could be chest pain, it could be a fall, it could be a domestic situation. And if we find out that the patient is using, this is the time when we do a ROD screen. And if the ROD score is greater than 3, that patient will be offered a chance to go through the Suboxone treatment. At that point, a COWS assessment, a quantitative assessment is done. And again, if it's equal to or greater than 10, they're a candidate for induction in the ED. If it's less than 10, they go this way, and then they get referred to our partners in the community, and this could be CleanSlate. Suboxone is not the only tool we have. You heard about naltrexone, which is very effective as well. We have patients who will do better on methadone. And that's a topic for another day. I just wanted to go over some MAT contraindications, and one of them is that if they received methadone in the past 5 days, pregnancy is not a contraindication. In fact, we've been using Suboxone in our obstetrics inpatient unit for a while, and our collaborative care physicians, clinicians, our social worker, has a healthy interface with our obstetricians. This is a population that's underserved, and the one patient population that is at risk to die from an overdose is what? Does anyone know? Because most patients with opioid withdrawal will not die, except for this tiny percentage. Which patient population can die from an opioid withdrawal syndrome? Anyone know? It's the infant. It's the infant born of an opioid-dependent mother. Otherwise, most patients will make a lot of noise, but they're not going to die on you. The lethality with the opioid dependent patient is with an overdose. The other warning is about the concurrent use of benzodiazepines. And one of the things that we're trying to do with our primary care physicians is to make sure that they understand that it's a lot easier to give a prescription for lorazepam and a lot harder to take it back. And unfortunately, the issue with concurrent use of benzodiazepines is the risk of respiratory suppression is much higher when you use opioids in conjunction with benzodiazepines. So if I can go back to the slide that Sarah and had put out earlier, which compares the disease models of hypertension and opioid withdrawal and opioid dependent patients, it's a paradigm shift for an addiction psychiatrist, because for benzodiazepines, for sedative hypnotics, for alcohol, the treatment plan is to get them off completely. There is no such thing as controlled use of any of those substances. So sobriety, complete sobriety, is the end goal. With opioid dependence, the name of the game is maintenance. You need them to achieve their new normal so that they're not craving. So the challenge here is to make sure that people are educated and understand that they need to be on maintenance therapy, whether it's methadone, whether it's Suboxone or naltrexone. So, what's next? This is the rods. It's fairly straightforward. If you've used any of those substances, you go on to the next set of questions. If you haven't used them, then you don't qualify. You don't have to answer questions 2 to 8. And again, the score is greater than 3, and you qualify as somebody with an opioid dependent syndrome.
And most important to our project and success is that we have partnerships with the community. So 24 hours a day, 7 days a week, we can do an expedited referral for next day business appointment. With CleanSlate, it works extremely smoothly. It is very common for somebody to leave the emergency room and walk across the parking lot and start their intake right then and there, or be discharged from the hospital in the same way and start the intake. We also work with all the other community providers in the area based on where the individual may already have been connected with and what's worked well for them, or due to their age or special needs. But I think it's really important for you to be aware out in the field what an individual should expect when going into a provider like CleanSlate.
So I'm just going to give a little overview of how a CleanSlate program works. Most programs work the same, some work different. So for us, we were very, very, very lucky to be on the BID campus and be able to support this initiative. It really is amazing that people are able to not even get a ride. Transportation is a huge barrier with a lot of people. So right now we can say, well, you don't need transportation, you can just walk. I'm able to get patients in within 24 hours, sometimes same day. I always encourage everybody to walk over anyways. Even if I don't have an appointment, we can get paperwork done. You can get familiar with the staff. I have a care coordinator on site too. You can meet with that care coordinator. Maybe you need a primary care or a PT1. Anything that you can think of, my care coordinator will help. You want to take GED classes, she'll look it up and help. She'll make phone calls for primary care. That can be really frustrating for somebody newly in recovery of putting their lives back together. Well, now I need a doctor. I need to start taking care of my health. I need to make sure that everything else is kind of falling into place. So my care coordinator, Allie, will sit with them, make phone calls, make follow-up phone calls. I don't know if anybody has ever got on the phone with Mass Health or Department of Transitional Assistance. It's infuriating sometimes. You're on hold for 45 minutes. You just want to hang up. You're in early recovery. You don't have time for that. You just really want to just give up. Allie will sit with people for as long as it takes to make sure that they get all their ducks in a row to make sure that they can get the best care that they have. We also, any time of day, Sarah or one of her staff members will call me, and I'll do an intake right there. I usually have my computer with me. I can run insurance and get somebody in as soon as possible. For us, striking while the iron's hot, if somebody says they want treatment, I think it's really important to strike at that moment. Because in 5 minutes, 10 minutes, or another day, it could change. We send them home, they get comfy, they start falling into the same practices they were falling in before. So to make sure that we can walk over, we're very lucky to have this relationship. When a patient does come in to an appointment at CleanSlate, it will be about an hour for your first appointment between the paperwork and the urine screens and the blood work, and seeing somebody and going over your history. I mean, we're gonna start from the very beginning and we're gonna go all the way to what's going on now. So it would be about an hour. Every patient does have to give a urine screen at every visit. I try to make sure that my office is always comforting and warming and welcoming. It is a medical office, so we do make sure that we keep to medical standards, but also I want to make sure that my front desk is inviting and happy and smiling, because it's terrifying walking through that door for the first time. So we just try to make sure that, I had a patient as I was actually leaving today coming in, she was sobbing. I made sure she was put in a different room so she didn't, whatever was going on in that moment, she didn't need to sit there and have everybody watch her sob in the waiting room. We just really want to make sure that we take care of everybody and meet them where they're at. If she's having a bad day, we're going to meet her where she's at. We're going to get her into a different room. If you're having a great day and you want to share a positive story with somebody in the waiting room, I support that. But we're not talking about anything that might have got you there or what you were using in the past. I try to say rainbows and cupcakes and sunshine and unicorns only. We can't talk about the bad stuff. I just want to make sure that everyone knows that it's a safe, comfortable place where you can get help and you're not going to be judged for anything that you've done in the past. So we do urine screens at every visit. We also make sure that everybody brings in their prescription with them at every visit. We want to make sure that you have your prescription, that you're taking it properly, that you're not, giving them out to somebody else, you're not diverting. It's really important that we hold people accountable. And if you are diverting, we're not going to say, there's the door, see you later. We're going to work with you. Well, what's going on? Why is this happening? We also have a licensed alcohol drug counselor on staff where he's able to kind of meet with the provider or meet alone, where patients can also get that little counseling part. It is rather temporary. If there's something more in depth that the patient might need to discuss, whether it's like grieving a relative or loss of somebody, we make sure that we get them to the appropriate person that can touch on those aspects of their recovery with them. And then we make sure we have groups. We have groups for patients. We have a relapse prevention group that runs every Wednesday night. We are open till 8 p.m. on Wednesday nights for our working class crew that come in. It's the solid group of people that come in every Wednesday from 5 to 8. It's really nice to see everyone kind of come in off the streets, off their landscaping job or whatever, and everyone kind of gets familiar with each other. It's a great place to they're sharing numbers, they're giving each other encouragement. It's really, really awesome to see as people progress and they start working more. We still offer that 8 p.m. appointment for you because we want you to work ultimately. We don't, it does not stick to this 9 to 5 where you have to come in at that point. We do make sure that if a patient does come up positive for any kind of substance, that we talk about it and we bring them in closer. So that might mean they have to see our LADAC every single time. That might mean that they have 2 appointments every week. We're not about just sending people back out into the street and saying, you messed up, see you later. Because ultimately, relapses can be a part of recovery. Not always, but it can be. So we want to address it. We want to make sure that, we're giving the patient everything they need in order to succeed. If it is an ongoing
thing where it's positive, it's positive, it's positive, it doesn't seem like we're helping, we will refer to a higher level of care, whether that be a detox, an IOP, intensive outpatient, a SOAP program, anything like that. And we'll make sure that you can come back to our program and start again. And I think that's really it with our program.